So happy Friday, everyone, and welcome to the next session of our 12-week tutorial series. Hope everyone had a great 4th of July holiday and excited to move forward with this series. So today we have Kane, who will be talking to us about healthcare. And I'll turn it over to Chris in a moment. But I wanted to introduce a couple of new things that we can do this week. So Zoom has updated the app, and there is a new feature that is available to us now. So if all of you want to just click on that button which says participants, it will show up a list of participants, and I'll let you do that. And once you are there, on the bottom right-hand corner of that window of participants window, you will see a thing which says raise your hand. So if any of you have a question that you want to ask, you can raise your hand now. So you can just press the raise your hand button, and it will flag us, both Bruce, myself, and Chris. We'll see that raised hand, and we can call on you to ask your question. So that's just a new feature that we have. So last time during our last session, I know it was very interactive and very helpful for all of us to be able to interact. So this raise your hand feature just does that even better. So if some of you would like to just try that for now, just those who have found that raise your hand button, just press on it so we can see that it's working. There you go, Brock, Sharmili, Justin, great. All right, so it's working for some. Can I ask like everyone who is on to raise their hand just so that I know that people have found it? We'll give everyone a minute. Maybe a couple more. Okay. All right, so I guess a lot of folks are finding it. So that's just a reason. Go ahead and lower your hand now, so I know you have that. As usual, of course, if you have any other questions, you can always type it into the chat window, and we'll make sure Chris can take a look at that. I know Chris would like this to be interactive as well. So feel free to ask questions as you are going. Justin and Pedro, could you lower the hand? All right, great. Awesome. So we have got that technology thing out of the way. So let's turn to our main discussion here. So we have Kane. He's the Chief Strategy Officer at Phoebe Putney in Albany, Georgia. Pretty sure he has a story to tell about all the COVID thing that happened over there. But today what we are going to talk about is healthcare. Now, healthcare is an interesting topic in that it forms a pretty large chunk of your questions. But from a preparation point of view, it's a lot of information that you should just have as a healthcare executive. So Chris will go over a number of topics, and we encourage you to keep reading, keep yourself informed about current events in healthcare and all of that. And I think that will be really helpful as you prepare about your exam. Of course, as I mentioned before, it takes a while for ACHE to put in new questions about healthcare events. So don't think any questions will be there on like COVID, because those are just current events. So, but to the extent things happened like a few years back, there may be some questions. So Chris is going to do an overview of the healthcare section and cover several topics in there. So with that introduction, I will ask Chris to take over, give his introduction, and then take it from there. Chris?
Thanks a lot, Raul. So greetings from Albany, Georgia, or if you prefer, Albany. And as Raul mentioned, we have had an interesting COVID experience. And just in the last week, we've actually had some additional admissions bump up in our hospitals. I think our inpatient census right now for our health system is 50 associated with COVID. And so it was an interesting process. I've started here 3 months ago in a newly created position, and I started in the midst of COVID breaking out, and first time in my career I wore a mask with my suit and tie. And so now I have a collection, including my Phoebe embroidered mask that I'm required to wear appropriately. And so I'm happy to be here today, and I know that you may be texting your kids or writing an email to your boss, and that's okay. That's just the nature of how we do things these days. And this course arguably could be a self-study, read the slide deck, but that's not what we have. And I'm going to pull up my slides as we go, but here's my contact information for now or in the future. If I can ever be of help to you, reach out to me. I'm not certain that my remarks will trigger any controversy or burning questions, but feel free. And you notice that the slide deck that was sent to y'all was 134 slides, which I will apologize for, but it's the accumulation of prior speakers' slides. I think I've been doing this for maybe 3 years now, and all the attachments are from the prior speaker, which may have been Glenn Pearson from GHA years ago. But we're not going to go over the appendices and the questions from the exam unless someone wants to. Happy to, but the explanation is in there. So today, it's just kind of an overview of the industry. Kind of more fun for you and me if we were in the same room, because then I could pause and get your reaction, but I'll attempt to do the same in a virtual format. But as Raul mentioned, the questions are not updated extensively. The sample questions, if you had a chance to look at them, actually make reference to HMOs and some other nomenclature that is not commonly used these days. I can say I'm old enough to know some of the old nomenclature. As a bit of trivia, I was at the time we called it the chairman of GAHE, not the president, but I was the elected head of the organization in 1990. So please don't raise your hand and tell me you weren't even born then. But I am now. I go to meetings and people have no idea who I am, which is fine because I'm on the verge of Medicare myself, in not too many years. But at that time, it was an organization for alumni of Georgia State University's programs, and we just incorporated in 1990 and expanded into a broader membership base that encompassed obviously a lot of people, and it's been a great chapter. But anyway, this will be an easy class. My intention is not to get to the point that we're going into details and trivia. I guess this slide had more importance when we could actually visualize a college classroom, which seems irrelevant these days. Nor do I want to do this. If any of you result in a head on your computer at your desk, tell Raul and he'll politely tell me, but we're going to try and make this informative and interactive. So the actual exam is a little less than 1/5 of the overall fellowship exam. Historically, it's been about 36 questions. And as you can see, multiple choice, and you want to be prepared. I'd suggest to you that these websites that I've pulled up now are very helpful if you want to refresh yourself on some of the nomenclature and some of the acronyms. I did not serve in the military, but my sense is that healthcare rivals only the military in the number of acronyms. So for those of you that were in the military, maybe you have a head start in learning and remembering acronyms, but these would be some good resources for you. So I took the liberty of doing some myths in healthcare, and here are 6 for your consideration. I highlighted in red the last one because while COVID is prominent in our thinking as an industry, there's so many other things we need to address. It's interesting for me to be in a strategic planning role at a health system because we were the epicenter of COVID in March and April. However, there are a lot of other business issues that I work on above and beyond COVID, but COVID and its impact are very real. And I'll give you a tangible example in our health system where the GMA, the state equivalent of FEMA, with the assistance of Governor Kemp and others, constructed a 24-bed modular unit on the campus of our Phoebe North hospital. And it was remarkable in the speed of its construction and also its innovation in creating a modular hospital that's capable of taking care of very sick patients, not ICU beds, but nevertheless very sophisticated. So things like facility design and flexibility and staffing, as you know, have all had ripple effects associated with the COVID outbreak. So in that regard, it'll probably be a lasting impact. Talking about some of the other aspects on this slide, the mandate for pricing disclosure will be interesting as we go forward because as an industry, we really have not worried about pricing and its effect on behavior. And the concept in other businesses of the price elasticity of demand is how will demand change if you change the price. We don't have that sophistication typically, but that's starting to evolve with the mandated federal regulations. Clearly, we have a long way to go from being required to post our charge master in searchable form into relevant consumer-based pricing, but we're headed there. I think the idea that health systems will employ all physicians, another myth, but some people may perceive that that's where we're headed. Affordable Care Act, notwithstanding headlines that the Republican Party wants to eliminate it, clearly the population likes many aspects of it. But some of the nuances of that, the accountant that does my taxes sent me an email that said I could submit an appeal by next week to preserve my right to get a refund on ACA related premiums I've paid if it's deemed unconstitutional. So call me lazy, but I told the accountant I'm not going to spend time on that goose chase because I don't think it's going to be deemed unconstitutional. But let's see what else. Medicare is very efficient. That's a headline I would say is a myth. The idea that IT reduces costs is, I think, a myth. And years ago when I worked at Wellstar, our CEO at that time had the benchmark that for every hospital you implement Epic in is a $50 million price tag. I'm guessing it's even higher now, but by the time you do all the updates and monitoring and maintenance of it, I don't know that you'd say it reduces costs. So continuing on, healthcare being unaffordable, I'm sure many of you have heard that remark. When I was self-employed as a partner in a consulting firm, my family's premium for health, dental, and vision insurance was almost $35,000 for calendar year 20. So I endorse the idea that it is unaffordable these days, and I'm curious how the employer sector will manage this. And that brings me to my next slide, which, while it's an old quote now, over 2 years old, Warren Buffett's comment was the precedent for Amazon, Berkshire, and JP Morgan to create the new company Haven. And I'm sure you saw that when that was announced, the actual stocks of some of the healthcare companies, including the payers, dipped down for a week or two because there was anxiety on what effect this organization might have. And I want to say their aggregate covered lives may be in the range of 1 million or over 1 million people. But just this week, I saw an article that said that Haven has not really gotten traction or conveyed what their priorities are or impact. Their CEO, Dr. Gawande, actually stepped down a few months ago. So more to come on that, but I bring it up in this session just that sometimes as an industry, we perhaps underestimate the impact of our business model, which is largely correlated with employer-based coverage. And then we have some other innovation, the Walmart Centers of Excellence, and this is an article from Becker's, but the element in the red box to me was astounding, that of those that went to the Mayo Clinic for cancer, more than 10% learn that they don't have cancer, and 55% receive a different treatment plan. And it's a little scary to think that if other employers mimic Walmart, that some bread and butter referral patterns that have come to your health system could be in jeopardy. And I could use Phoebe Putney Health System as an example, that our cancer program is large, and while not a material number of our population here works for Walmart, every little bit counts, and if part of the commercially insured population gets siphoned away due to this and other innovative business models, then it just puts more pressure on a very margin pressured industry in healthcare delivery. So I forgot to encourage you to just speak up into your computer with or use the raise your hand signal on Zoom, but I'm going to stop talking for a moment and allow others to speak with comments or questions. So either I've astounded you with my observations or you're all doing email and don't have any comments to make, but anything out there for questions or comments?
None yet.
All right. And I know a couple of you from looking at the list of attendees, so I'm expecting those of you who I actually know or used to work with that you'll make me look good and give me a pause. So think of a question. So when I have been asked to go speak at healthcare days for chambers of commerce or other presentations, I kind of try to reduce healthcare into this slide that's on your screens now, which is value is quality divided by cost times access. And some people would say, well, you don't need to put access in there, that it's embedded elsewhere. But I kind of view this as why we all are in the industry we're in, and how every one of our jobs, even if you're in a corporate support role like mine, you are working directly or indirectly in one elements of this equation. So I know we haven't mastered some of the aspects of this, but at least it gives us the formula to pursue. And the item under access telehealth was a couple of years ago when I used this slide, I could say, well, that's kind of a cool thing that's evolving, and now it's become ubiquitous. And we, like other health systems, are trying to grow it in a way that is consumer friendly, with uncertainty about the future of the reimbursement, the HIPAA waivers, and some of the other things that have enabled us to do it with COVID. But in the case of Phoebe, we had a couple physicians and other leaders that I think put it together in about 72 hours of here's what we need to do and here's the platform we're going to use. So that was kind of interesting in terms of the speed of the impact. But the business issue for us is that the best platform going forward if we anticipate that the comfort level and preference of patients to use telehealth will continue? And of course, the quantitative issue is what is the substitution effect of regular visits now into telehealth, and how much will that stay as the COVID environment stabilizes or surges or diminishes going forward? And so if any of you have the detailed answer on that, please share it with me. So this is an old email, but it kind of underscores the aspect of financing healthcare with the inherent subsidy of commercially insured patients toward Medicare, Medicaid, and indigent patients. And we probably haven't done ourselves any favors as an industry by trying to obscure the business model or talk about charges and charges foregone as a community benefit in some cases over the years. But again, in talking to the community, they don't fully understand the subsidy effect that occurs. And again, simplistic, but the next slide is another one that I will use with the community to say it's not to scale, but this is how the world works. And the other one that's hard to understand but has not changed in many years, this is a slide from healthcare spending in 2010, but last time I looked it was the same, so I used the same slide, is 5% of the population uses half of the healthcare resources, and the bottom 50% only use 3%. And this really, for our industry, of course, has been the genesis of population health and risk tiers in trying to locate and manage these people. And some of it is very appropriate of how do you intervene and get people to change behavior. And some years ago, because of my body mass index, was assigned a health coach. And fortunately, since then, I've lost 40 pounds, I think, by changing my habits. But at that time, I was still sure I'll have a beer and some chips. And my circumstance was that finally it was like a high school breakup. I said to my coach, this isn't working for either one of us, so why don't we just take a time out? Because I would have the phone call, but I wouldn't change my behaviors. And now we're, as an industry, even more attention to, is there a business model that enables physicians and hospitals to be paid for the prevention stage of activities instead of the diagnosis, treatment, and rehab? Those last 3 stages of diagnosis, treatment, and rehab are where we as an industry have created all our margin. And there have been some notable efforts to make the communities aware of preventive activity. And for those of you that are based in Metro Atlanta, I don't know if it was 7 or 10 years ago, CHOA had some billboards that tried to call attention to childhood obesity, and some people objected to it, saying that you were making fun of those children. And I would defend CHOA and say, to their credit, they were trying to change the lens that people look at health and health spending and our health economy. But as I recall, the billboards did not last long. So how would we look at how would I look at the outlook by sector? And I think you could change this every day, but some weeks ago when I sent the slides to GAHE, this was my view of the world, and that the role in the continuum of care in post-acute is to be determined, but COVID has created a lot of anxiety about the post-acute world, but at the same time, a sense of, is there a way to use post-acute resources in a manner that complements the treatment of COVID? And the hospital industry, which many of us work in, has been fascinating just to see the scale of some of the organizations. And just this week, the North Carolina, New Hanover Health System had a bidding war with, I believe it was Atrium, Novant, and Duke, all expressing an interest in that health system. And the Novant won the beauty show, tentatively subject to formal approval, with a commitment of over $3 billion in the future. So, or you look at the idea that Advocate would merge with, was it Beaumont, which would create a massive health system as well. So this idea of too big to fail and scaling up continues to be noteworthy in the acute care sector. So let me pause again. Questions, comments, agreement, disagreement? What's your view of all this? Raul, are the lines open? Can I ask for an amen from the congregation, or?
Amen.
Thank you. All right. Organ transplants, again, this may not seem related to the exam, and it's not. I just was trying to do a drive-by of the industry, but the whole dynamic of offering to be an organ donor and the volumes of what's needed and how we allocate organs with the organ donation zones and the like, and compare that with some other countries that actually pay people that donate organs. It's a small, but I think very interesting aspect of our healthcare system in the U.S. Some years ago, I did a business plan for an academic medical center's transplant program, and it was fascinating about the sophistication of it, about the competition within transplant centers for having the outcomes, the volumes, and the credibility, and how there was a halo effect from it. But anyway, for your information, the next slide about profit margins. We're in an industry, at least for a tax-exempt health system, let's ignore COVID for the moment. If you can have a sustained operating margin of 5% or higher, you're viewed as a relatively high performer when you go to the bond rating agencies. But then when you look at the Fortune 500 world, as this slide does, it's amazing how the profitability varies. And Visa credit card, a 50% margin in their 2018 fiscal year. Facebook the same. Facebook has some challenges of late. But then you look at Walmart, and that was surprising to me that they had a 1% margin. But when you look at the revenue base, it's still an enormous amount of cash flow. Drop down to healthcare, and the investor owns are kind of small players in terms of profitability margins. HCA was at 8%, and some of the payers. But I think there's this sense in the community sometimes that in light of what healthcare costs, that their inference is that there must be incredible profit margins. So part of our challenge in the industry is to convey that 24/7 enterprises are not necessarily profitable, and we are unique in our labor intensity and our capital intensity. This slide I thought was interesting. I want to say I saw it in an article on LinkedIn or somewhere, but it could be updated now and new logos and the like. But this Greg McKelvey, I thought, did an outstanding job of new categories within the healthcare industry as a whole and some of the different players out there. And to think how we are migrating sectors and combining sectors. You look at Pittsburgh with Healthmark, who's been operating a health system and a health plan for a number of years, as has Henry Ford Health System or Intermountain, or I think Centera, all have their own health plan and have for a number of years. And then you look at United Healthcare, which is acquiring a huge number of physician practices around the country. So the whole competitive landscape has changed dramatically. And just in the last week, you had Walgreens announce their partnership with Village MD and $1 billion investment to open up hundreds of primary care centers attached to Walgreens. Look at Walmart in our state with their facilities in Paulding County, Dallas, I recall, Loganville, and I forget where the third one was opened up. But we now have new competition, which is both interesting but daunting if we contemplate what the future looks like in terms of the investments we need to make and which ones we do not need to make. So, but maybe I'm just talking as the strategic planning guy too much. You in the operations field have your own set of challenges that trickle down from the competitive landscape. the federal government and a focus on fraud, the vast majority of the collections from fraud are associated with healthcare. And just this week, I was talking to one of my colleagues at Phoebe Putney Health System, and he spent 10 years with the FBI, some of which on healthcare fraud. And it's just interesting how attractive it is to the government to try and claw back some of the money. Probably 25 years ago or more, I remember I gave a presentation to the Mississippi HFMA. I was sitting at a table at lunch, and one of the other speakers was a federal agent. I don't know if he was Bureau of Alcohol and Firearms or DEA, I don't remember, but I recall he said basically that the career path in the early 90s shifted for some federal agents away from chasing the mafia to chasing healthcare fraud. And it was just that was the way to advance within the federal agency. So let's hope there's not a new wave of that, but clearly we've been an entity with great oversight of the regulatory. Hospitals and health systems. This slide is old yet relevant, that in the early 90s, there was a book written called Remaking Healthcare. A couple of the authors were some of my partners at that time at KPMG, Pete Marwick. But the premise was that there was this integrated delivery system concept, and you could quibble on the nature of the interactions among the boxes on this slide, but it varied from assuming that the future would be capitated payments with a central revenue stream coming from the top of the slide to other arrangements, but it addressed what were the clinical handoffs, the information system handoffs, the economic incentives across all the different provider pieces of a system. And I'd submit to you that we as an industry, at least in the health system side of things, we are still challenged with having a high performing delivery system across these dimensions. And granted, some of the employed physicians have migrated more and more. I don't know if I have the slide in this deck, but there's a organization that tracks that, and about a year or so ago, their data suggested that 42% of physicians in the United States were employed by other entities, be it hospitals or insurance companies and the like. And part of that, of course, is generational. Part of it is this quest for integration. Here in our health system, we employ about 40% of the physicians in the area, and 60% are independent. So we, like others, have kind of gone down that path. What about the operating environment of health systems? And clearly uncertainty, the tight margins I've mentioned, the capital access. It was interesting recently talking to some of the rating agency people as we were having our bond rating reviewed for Phoebe Putney Health System. And one of the people said that they rate all sorts of industries. So they're trying to rate the bond creditworthiness of the airlines and the cruise industries. And one of the people had commented that they can't really hold them accountable for COVID. That was just somewhat of an act of God. But the same parallel business issues exist in those industries as in our own, which is, when will there be confidence in consumers coming back? What's the requisite capacity to manage the demand if you forecast it correctly? And what's the resource commitment? So I find it interesting that there are some parallels between our industry and others. The dimension unique to our situation, of course, is a medical staff and delegating decisions about the use of our services to other parties. And whether they're employed or not, there are other parties that are making the critical decisions. Consumer expectations. We're in an industry where people expect the responsiveness of Starbucks. I want my MRI now. I asked for it, or I've been sitting in your ED and I'm frustrated that I'm here 4 hours. Why can't you do a better job? And they have a point. So I wrote at the bottom on sustainable business model, and I don't mean to be pessimistic. I put that in there on two fronts. In one scenario, might we or other conglomerate health organizations be held accountable based on a fixed price, call it capitation or a global budget? And we did that in the early 90s, and it was deemed a negative because it was an incentive to withhold access to care. But clearly our transparency on quality and access has improved since then. Or the other view of the world, we can look at the Maryland system of care where there's a fixed budget, but at least for hospitals has eliminated the outright warfare to try and steal admissions from each other once that budget is set for the upcoming year. So there are different models out there. And the other anxiety perhaps is that what if the frustration with healthcare comes to the point that it is more regulated, almost like a utility? And while that may be a low probability, it's something that we as leaders in the industry can think about. What is the future going to have for us? The triple aim, I don't need to explain that to any of you, but now you hear discussion of the quadruple aim. And I had clients when I was a consultant who talked about adding a fourth dimension, either the health equity or the joy of work and burnout, and how do we retain our team members. Clearly, just in the last few months with COVID, health equity would be a big front runner in what other dimension warrants significant attention from the entire healthcare industry, whether it's as an employer, as a healthcare delivery enterprise, as an insurer, as a pharmaceutical company. And so more on that. Let me pause again now. Questions, comments? I know you must have them because I'm not this good to just amaze you with my insights. So,
hey, Chris, if you don't mind going back a little ways to the Walmart discussion, do you feel like private companies like Walmart have a better handle on what a center of excellence should be than the federal government? Or, for that matter, Joint Commission?
can I vote that none of them know?
Yes.
Let me piece that together. I think a large employer, I'm going to go back verbally, not slide-wise. Is that okay? So I think Walmart, because of the scale of its covered lives and its incredible focus on healthcare as a supply chain cost item, appropriately went down the center of excellence path, as have others in the Houston market and different places. So I think employers with the right scale can pursue that. As a specific example, I did a large consulting project for Mohawk Industries, which is a Fortune 400 in Calhoun, Georgia. And I kind of pitched the idea of a center of excellence and bidding out elective high-end procedures. And at that time, a few years ago, they did not pursue that because they were more focused on getting a narrow network that addressed their needs. They even have their own remarkable black box formula for evaluating providers. So I think center of excellence makes sense. I don't have confidence in the CMS to design that. I'm not particularly impressed with our value-based care initiatives for all the money it costs to participate, all the reluctance of payers to share the data. And while in good faith, providers said, let's get our toe in the water with value-based care and being a risk that then could migrate towards other things like centers of excellence, the industry has not gone down that path at the same speed that was expected. So CMS, no, I think regional health systems and partnerships could develop centers of excellence and pursue their employers. And I'm surprised it hasn't happened more. So for example, in Georgia, I understand and have observed health systems in the last 10 years that have gone to Coca-Cola, have gone to Delta and said, make us the preferred network for heart surgery or orthopedic and the like, but to my knowledge have not been able to execute those kinds of agreements. Maybe that will change, but I think it's a great opportunity for health systems, and I think it's a great opportunity for employers.
Thank you.
Other questions or comments?
I think it's that's a pretty pessimistic view. I'd be interested to hear how relevant you think hospitals will be in the future. With the Walmarts of the world offering MRIs and the Starbucks mentality of one service now. I think there's some innovative and integrative models that are coming up, and I'm young, but I'm questioning the relevancy of hospitals 50 years from now in some capacities, not every capacity, but in some capacities.
Well, a few things. I don't mean to be pessimistic, and as someone who is past age 60, I'm hoping some great hospitals exist for the next 20 years, God willing for me. On that point, I'll go back to when I worked at Wellstar and in a similar strategy role, and I was doing a presentation on healthcare and Wellstar to a group of community leaders, and one of them raised their hand and said, well, Chris, I know that there's a mission for Wellstar, but if all you wanted to do was maximize the profit, what should Wellstar do? And I said, close the hospitals. So might I say that wasn't a popular answer with the facial expressions of the attendees, but it was an honest answer of the margin at that time, and arguably still was, in the outpatient. So I don't see how we eliminate hospitals, and the COVID circumstance has really highlighted the need to have sufficient bed capacity, literally, in communities to accommodate this. So I think there is a role for hospitals. I think the struggle is, how can we reduce the cost escalation? And so the transactional nature of healthcare is good. The retail medicine is good. If that's what the market wants, then everyone ought to jump in and compete and pursue it. But there's going to be a need for physicians and for hospitals in the future. And I call attention to rural healthcare. We have some of our hospitals are in rural areas that are part of Phoebe. And they are major employers. They are the lifeblood of access to healthcare. And so it's a very tangible circumstance for me in this role to see more the long-term perspective of how do you manage the health of a population. But you said you were relatively young. I think it's a really exciting time to be in healthcare. The people in my generation aspired to become a hospital CEO. Well, now there's so many options for well-informed, fellowship exam passed, I'll say, exams, to go out and work elsewhere in healthcare. I mean, think of the opportunity to go work for a private equity group that wants to discern investments in healthcare, or a physician enterprise 10 years from now that takes a revenue stream and manages the health of people and buys hospital capacity from local hospitals. There's so many scenarios that should create a lot of excitement and optimism about healthcare as a career. So if I conveyed a pessimistic view, I apologize, because I'd rather view it as cautious, yet aware of the different decision trees and paths we could go down as an industry. So thank you for your question and comment.
Yep, thank you.
Other thoughts and comments or questions? All right, we'll continue on. So I skipped the slide about cost escalation, that's self-explanatory, but this whole idea of pricing and transparency and disclosure, and this was an interesting study that was, you could Google and find it, but a business coalition in Indiana and the Rand Institute were sponsors of this, and it kind of looked at what are the actual amounts paid for commercial healthcare versus Medicare rates. And the Kaiser Family Foundation, KFF.org, just in the last couple of weeks came out with a similar review that I want to say said commercial rates or commercial payments were roughly 219% of what Medicare pays. So two reasons I mentioned this to y'all. One is it just illustrates and quantifies the cross-subsidy aspect that I described 45 minutes ago. And the other is this issue of transparency. So if the federal government prevails in mandating disclosures of the rates that people have negotiated, all hell is going to break loose in the provider industry, because it will now just be an open secret on what was deemed a trade secret for decades now. And I just am curious what will happen after that. Once someone knows what their competitor are getting paid, will that just, if you have the requisite leverage, get you the opportunity to ask for a rate increase? Or will the payers just say, no, we have the leverage and we're going to ratchet down the rates to below the median and exert our power? I don't know the outcome, but it will certainly create a lot of debate, analysis, and litigation going forward. So to me, an interesting topic. Related to price transparency, here's a snapshot of what some other states have done. And if you look in the fifth column, what's the nature, fourth and fifth columns, what's the nature of the information? It's still going to be a bit macro for consumers that are out there. It's a good first effort, but it starts to get very complex in updating it, getting the information, and also educating consumers on how do you use the information. So we're starting to see an intersection of things now, from pricing and surprise billing, that all play into this premise that consumers want a more active role and more choices. And I think that's an exciting part of our industry going forward. Physicians, the private practice and the regulatory compliance, you all live and breathe it every day, and the different anecdotes out there. I think, was it a year or two ago, for example, there was a 2 or 3 physician practice in Michigan that was held hostage over their medical records in a cyber attack, and they closed their practice. How many people are confronted with that dilemma? That's unusual. New physicians have different expectations for balancing the quality of life and career. And, sometimes if you have friends and relatives in the industry as physicians, the macro business issues that you all deal with day to day become very apparent when someone gives you a real life example. So one real life example I had in the last couple of years was a pediatric cardiologist who was saying to me that he was planning to use an implant for something in a child related to cardiac, and the hospital had a preferred vendor that was not the vendor that this physician wanted to use. And the physician's comment was, for the sake of a $300 difference, I was required to put in the other implant, which worked, but wouldn't last as long. The implant that the doctor had wanted to use would have lasted longer and had an ROI, but based on the strict rules, he was precluded from using it. So it was kind of interesting to me that the policy initiatives we pursue have anecdotal individual impacts. And in this case, it may well have been the right decision to not give the physician that latitude. But we see a lot of health systems appropriately looking at their physician preference items and starting to narrow that down in the interest of cost management, which is certainly very prudent. Contradictory messages for physicians. So the example I'll use with employed physicians is we've evolved into a RVU payment methodology, but in the next breath we say we want you to manage health and do preventive activities, but we've created a compensation incentive that, notwithstanding a citizenship element, is still a volume-driven incentive for physicians. So again, I don't mean to preach to the choir. This is the slide I'd mentioned earlier. Actually, I told you 42%, but I'm proved wrong. It's 44% as of January of 2018. But for future reference, this Physician Advocacy Institute is an interesting website that periodically updates the industry trends. And of course, it varies by specialty. As examples, orthopedics, relatively low percentage of employed physicians. Clearly, they have multiple revenue streams to maintain their current business model, whereas cardiologists in the last 10 years have really showed a huge interest in becoming employed by health systems. Primary care is being redefined. One could say that this slide is inaccurate since I wrote it because telehealth is used in primary care, but not all telehealth is primary care, clearly. We at Phoebe, and probably all as well, are using telehealth for cancer patients post-treatment or cardiology patients and people that have been discharged with peripherals that they can bring home and connect with us by way of telehealth. So a whole new domain there. Employer on-site activities, I'll mention Mohawk as an example. They have at a couple of their major plants, they have an actual primary care clinic with a nurse practitioner supervised by a physician that you can go to. And they also have what they call near-site clinics, where for smaller locations, smaller plants, there is effectively a telehealth room that enables those people to remotely connect with clinicians at the mothership. So if you have an innovative mind, I think there are applications in primary care and beyond to grow your business. I've covered that slide. Nursing shortage. I was kind of surprised at the disparity here. If you had asked me before I'd read this article, where's the nursing shortage, I would have said every state, everywhere, but that's not the case based on this data. And for those of you that are involved in recruitment of clinical talent and the constraints, it seems that the one major constraint is just the number of nursing school faculty members who can ensure the expansion of the nursing students that can be educated. In the last month or so, our health system opened up an innovation lab. It takes up the entire floor of one of our medical office buildings. I want to say it's got to be 7,000 or 10,000 square feet at least, but it has got multiple mannequins that can be programmed for different health conditions, from delivery of babies to COVID symptoms, and train people and test people. What I found interesting was that all of it can be videotaped. Then the students can go to a classroom and in a non-threatening environment go through the videotape and say, what did we do right? What did we do wrong? And in light of our current situation in healthcare, where many nursing students were graduated early because of COVID, we are putting our nurse recruits through a couple months of intensive training in the lab to ensure that if they missed anything in their last couple months of school, that they catch up. So I think training nurses and the maximization of clinical licenses is a core business issue that we're going to be addressing. Let's go on to the Georgia market, which, having lived in Georgia for 39 years now, I'm proud that we are a microcosm of the entire industry of healthcare. And I won't go through each of these items, but from government agencies to investor-owned healthcare to not-for-profit, urban to rural, safety net, hospitals, we are a remarkable cross-section of the entire industry. Health insurance. Again, whether it's talking to physicians, talking to community members or board members, it's a way to say, how does healthcare work? And in some cases, as in this number, some people have more than one type of coverage. But our uninsured percentage has gone down, whether that's because of ACA or because of CHIPS and Medicaid for children. We as a country have done a good job on that. The direct purchase and marketplace coverage with layoffs from COVID, I think that's in the news now with more people buying it appropriately. There are some pitfalls there. I know from even helping a family member to buy on the marketplace, bought a health insurance policy a couple of years ago when being self-employed. And it wasn't until halfway into the benefit year that she learned that out-of-network coverage was not covered. So if she was traveling to visit friends in another state and went to the ED, it probably would not have been covered or elsewhere. So I think there's some pitfalls in buying insurance, but certainly we have various channels to pursue it. Average worker premiums, again, you can look at the annual survey that Mercer does and Kaiser Family Foundation profiles about employer healthcare and what the costs are. But to my earlier point, it is very expensive. Various employers are reluctant to keep using the lever of a high deductible health plan. There are some that are looking back at the traditional copay model to try to make it more affordable to people who don't use a lot of healthcare. Some of the mega deals out there, and just illustrates my point earlier about different sectors overlapping. The Anthem Cigna deal would have been pretty crazy to think that 50 million plus people would have been covered under the combined companies. The Department of Justice blocked that. As a Georgia example, I'm puzzled how the CVS Aetna deal was approved before the Northside Hospital Gwinnett Health System deal. Sometimes you can't even predict how federal agencies will review transactions, but the CVS Aetna deal went through relatively quickly with some tweaks to divestitures. I've covered that. I've covered that. Let me pause again. Questions, comments, anything I've said that offended you that I need to retract? Anything I should elaborate on? Raul, I'm going to pick on you. You've seen this session and others. Questions, comments, things to elaborate on?
Not at the moment, but I think Lisa has a question. Lisa, do you want to ask your question that you just sent to me? Or maybe I could read it out.
Sure.
So hospitals are choosing to move away from LPNs and using RNs and advanced practice nurses. And so, how does that, so when you talked about shortage, I guess the question here is, how does the cost of nursing change as you move to more skilled, more advanced nurses in this case? Is that the right
Sure.
question? So I think, so how does that impact the
Sure,
cost?
that's an excellent question because it combines some of the themes that I've mentioned in terms of cost management and clinical excellence and credibility. All of those play into that type of decision. So as an example, the LPNs can be greater supply of them, obviously at a lower wage, and leverage the time and intellectual capital. So I think it's a good business tactic, but it gets offset by nursing leaders who may push back and say, if we don't have the correct ratios of that, we're not rendering outstanding care, or it may be that it violates a formal approval process or recognition that nursing leadership is pursuing. So you have, of course, the Magnet program and others that may constrain going too far down that path. And yet, I think the fundamental premise is valid in that how do you have the right task for the right licensed people to do things? And so an RN can delegate things to the LPN. So I think it's a good strategy in light of the labor market, but I have also seen clients out there in the industry try to use nursing as a basis for differentiation, to be able to say if we're all RNs or we have this, it's parallel to people saying all of our physicians are board certified. There's a certain credibility dimension that one also has to address. And along that path beyond nursing, I think we're going to encounter other licensure restriction debates. So how many advanced practice professionals are physicians allowed to supervise? There was some legislation in Georgia that I want to say enabled that to be up to 5. Pharmacists, how far down the path we're going to go to afford pharmacists the ability to provide healthcare. And the deal that was announced this week with Village MD, the secondary commentary was that unlike Walmart, that's kind of going for actual service delivery of x-ray, dental, and primary care, the Walgreens assumption seems to be to embed pharmacists in primary care and go down that path. So the question about nursing and LPNs also leaks into other questions of license extension and optimizing the cost structure. So all very valid and all very relevant.
I would just add to that commentary, like just what I've seen in the market as a consultant, for example. There are 2 core issues I would say is everyone wants to practice at the top of their license. So, you know, an RN wants to do what maximum he or she is allowed to do. And same with the LPN, same with the CNA. So there's also a degree of job satisfaction if you get to do that. So to the extent you have the right mix of staffing, which allows each person to practice at the top of their license, it's much more satisfying. It's just something I've observed with clients and how they work and how the performance goes up when that happens.
That is an excellent point. I agree entirely. And so on the point of job engagement, I'll say that working in a health system, my satisfaction has gone up enormously because I don't have to do as many PowerPoints as I did as a consultant. So Raul, you have my empathy as you continue to do client reports. So
yeah, I do operational turnaround, so I actually create only 3 slides and then just talk about them for the next hours.
That's smart. I learned how to do lots of PowerPoints, as you can see from the massive deck I send you all. But going forward on the pharmaceutical sector, I think it's interesting to see how many drugs get approved. This is front and center now in the quest for a drug for COVID, as an example. Just last night, I was reading an article that was written in 2017. I was a little bit behind in my reading, but it was all about the 1918 flu epidemic. And it was almost prophetic in the author saying, if we have another outbreak, we're going to have to contend with people's reluctance to wear face coverings and things of that nature. So it was kind of interesting. So we'll see what happens on the drug approvals, but the whole public policy debate, the importation of drugs from other countries, and why does the United States pay as much as we do are all very interesting. This was from an investor relations deck from Walgreens, this idea of getting involved in the delivery. Again, I'm gonna kind of skip this because we've already talked about it. Just to illustrate why Walmart wants to be in healthcare, 90% of the United States lives within, I think, 10 miles of a Walmart. So now there is an alternative view. This Wharton School professor had this quote about a year ago. So I wonder if you're Frito-Lay, if you like this publicity that, hey, we got Doritos into a national article. But anyway, this person was not a fan of combining healthcare and snack foods. But of course, the market always wins, and if the market wants to get some aspects of healthcare at CVS or Walgreens or Walmart, it's going to happen. So I thought this is an interesting concept because even when I was an undergraduate and I I majored in public policy, basically health policy and also economics. And I remember we had a professor at that time, oh so long ago, was doing research on the value of a life. And we would be as guinea pigs taking surveys on, does this person with this profile have a higher value to society than this profile? But here the concept of a quali, or maybe it's pronounced quali, is how do you arrive at the value of a drug? And here's just one example that was pulled from the Wall Street Journal. I think it was Wall Street Journal. And but I just thought this was interesting. So there are people that are sitting at their desk with spreadsheets and trying to do this analysis to justify the drug pricing. But as you've seen in the industry, there are some drugs that are enormously expensive, in part because of the cost, but also in part because the people that will use them is a very narrow group of people. Health status. I find this interesting in that the yellow highlighted portion in the beginning, it's estimated that 12% of the population is health literate in being able to understand things. And that's a concern. We're trying to get people to behave differently. We're talking about population health management, and yet one could be discharged after a procedure or an inpatient stay with a stack of printed out discharge instructions, some of which are just Greek to the people reading it, and they don't necessarily know how to follow it. So many other things are correlated with patient compliance, with managing health and improving outcomes. And I don't have an answer there. I think it encompasses health education, but one can make a case it encompasses just general education. We need schools that ensure people have the knowledge and vocabulary and life skills to ensure that they can manage their health going forward. And then this is an interesting observation by Dr. Feinberg about genetic code. So are we going to get to the point where when babies are born, or maybe before they're born, there's going to be a genetic profile that's much more sophisticated than now, that instead of saying you're at risk for this, here's a map that has some very defensible statistics on it about your risk, or prophylactic treatments we're going to apply. But we can talk about the future of healthcare delivery and the question earlier about the future of hospitals, but there can even be a more substantive effect of just creating the demand for healthcare, period, based on science innovation. And I think that's pretty exciting. Pretty anxiety provoking, but also pretty exciting. Again, I'm going to skip this, but the chronic conditions, again, what was brought to home was in COVID, the mortality rate for comorbidities was very noticeable with some of the statistics. One can do this slide for any county in Georgia. I had just, I think, used this slide a year ago in Fulton County because it was a large county, but if you haven't done it already, this is kind of interesting for those of you that are in healthcare delivery with a physician group or a hospital or a health system, to pull up your local service area data and see where are the challenges. And I am particularly interested in behavioral health, and really I've worked with clients in behavioral health throughout my career, or health systems that had behavioral health, and the intersection of behavioral health and its effect on the demand for healthcare, whether it's patients with behavioral health needs that are in emergency rooms, and how do you manage that? At our large regional hospital for Phoebe Health here in Albany, we actually have a behavioral health emergency room embedded in our overall emergency room, with four rooms for isolated patient treatment of behavioral health patients that come in to our ED to try and address this community need, as well as the need for a special way to manage these types of patients. So I think behavioral health, inpatient and outpatient, is an interesting and enormously important aspect of our industry going forward. So let me move into final remarks and then open it up for questions and maybe end early potentially. There's never been anything more fascinating than the business of healthcare. I've spent my entire career in it, and I just think there's nothing that has both the societal impact and the complexity that healthcare does. And I know when I was in graduate school getting my MBA, I guess I hedged a little bit. I decided to get an MBA with healthcare emphasis instead of getting an MHA. And these days people get both, which is extraordinary. But I would have classmates that would get excited about, well, I'm going to get to interview with Procter & Gamble to be a brand manager. And I didn't say it, but I was a little cynical. Well, how can you get up every morning or every Monday and go to work and see how many cases of Pampers or whatever were sold in the prior week? I mean, how is that going to engage you? Whereas I always thought healthcare would just fulfill someone for an entire career, and I still think that's true. And as this quote says, I think there is vision and purpose in healthcare that affords vision and purpose in your career planning, starting with getting the fellowship exam passed. Hot topics, I mentioned health equity, artificial intelligence, the idea, for example, in reading x-rays applied to artificial intelligence versus human radiologists is shown consistency and efficiency that humans can't match. This idea of operational improvement is an enormous challenge that we as an industry have not been good at least on the hospital side. And I don't know how, I don't have any great answers to that. Raul maybe as an operational consultant, but nibbling around the edges may not do it. We could have a scenario where more federal and state resources are directed at departments of public health, and the Medicaid and Medicare budgets are tempered in their level of increase. So how are we going to take costs out of the system? Are we going to change the portfolio of services we offered? But I think the cost structure is a huge area. I've mentioned all the other aspects there. Medicaid budget, obvious, particularly in Georgia, where we debated its expansion. Certificate of need has been a debate around the country. I think right now about 35 states still have some aspect of CON. And now that I'm not a consultant, I'm kind of less involved in it, but there were years when most of my income was doing certificate of need applications and expert witness testimony. So I understand the process. I think unionization is something to watch, even though we're in Georgia. What's going to happen around the country as employees say, I was at risk because of COVID and other aspects of my job. And if my employers won't protect me and engage me, I feel obligated to reach out to a union. I think that is a very real business risk for our industry as a whole. So I will wrap up with, y'all are going to pass the exam easily, not because of this session, but because of the others that are more on point with the exam. And you will solve the puzzle. I'm going to pause now and say, are there any questions, or are there any exam questions in the appendix that y'all would like to review with me and the group? All right. Well, if Raul, you and Bruce and others don't see any questions submitted.
Yeah, I don't see anything over here, and no one is raising their hand. So I guess there are no questions at the moment. So I'll just take thanks, Chris, for doing this session. I know it's like one of those topics which is so broad that putting all of that in like an hour and a half or something is extremely challenging. So really appreciate your effort in putting this together. I have just a couple of announcements for the group or a couple of things to point out. I'm going to share my screen, and this is from our session last week. Okay. Hopefully you can see it. Bruce, can you confirm that you can see my screen?
Chris, you might need to stop sharing so that Rahul can share his. Or maybe it's Bruce sharing the screen.
All right, Raul, if this doesn't concern me, I'll just exit.
Oh, thanks.
How's that? All right, y'all, take care. Bye.
Thank you.
All right, can you see my screen now? Not.
Yeah, we can see it now.
Okay, so so hopefully you can see the PowerPoint presentation here. So wanted to just give a couple of updates. So last week when we talked about exam prep, so last time, we had mentioned this online community that's out there, or I thought it was out there, and because it was there until last year. So in the new updated website and all of that, this community no longer exists. So sorry about that misinformation, but we have confirmed that this doesn't exist anymore, and there are no plans to have that. So for now, that's not an option. Of course, as a fellow committee, we will look at if we can create something for Georgia, but it will take a while. So that's one update. The other update over here that I wanted to provide, a few of you had asked about exam questions in general and having a set of questions that you can take practice exams. So we checked with ACHE and they no longer offer any practice exams as such. And they suggested you should all just rely on the flashcards that are available from ACHE. So that's their suggestion. Again, a bummer that we don't have an official practice exam that we can provide for you at the moment, but just wanted to update you on that. Third thing, importantly, is I'm hoping, and let me stop sharing the screen so I can see all of you. So I hope everyone is getting all the emails that Bruce has been sending out, the weekly invitations, the material for it, you know, the follow-up videos, all of that. So can everyone, if you have been receiving those emails, can you raise your hand? So we are sure that you are receiving those emails. They may come from Constant Contact, or they may come from Bruce's personal email, which is brucelloyd@gmail.com. Okay, I see some hands. Waiting on others. Getting there. All right. I see only half the hands that are up. So Bruce has just in the chat window put in his email address over there. So please contact him if you are not receiving the emails or you're missing any of it. Please contact him so he can work with you to fix that situation. So that's important that you keep getting all these emails. So that was the one big point I wanted to raise today. So I think good session today, some good discussion. We will convene back again next Friday. Our topic is human resources. Another of those topics that's just across the organization, and it will overlap with some of our discussions previously. But hopefully a lot of new things will be introduced as well. So with that, I think we are going to end early, and I look forward to seeing you all next Friday. Have a great week.
Thanks, everybody. Bye-bye.